Hello and welcome. We are here at the ASCO update in Zurich. I'm Dr. Daniel Helbling, medical oncologist, and next to me is Dr. Köberle from the Hospital in Switzerland, near Basel. He's an expert in GI cancer, and I want to know from him what were the practice-changing studies from the ASCO 2013. Now, Dieter, you mentioned the study about calcium and magnesium and oxaliplatin. What were the main findings and what were the consequences for you?
Yeah, the study you're talking about was in the US conducted trial studying the addition of calcium magnesium to FOLFOX chemotherapy in the adjuvant setting. And the main finding is easy to conclude. There is no difference in terms of lowering effect of sensory, acute or chronic neuropathy in this trial. Therefore, this therapy is of no value, at least in the adjuvant setting, but I think we can also transpose this data to the advanced treatment setting and can conclude that we should abandon calcium magnesium infusion from the infusion room, so we get space for the infusion room, and start to think about other possibilities to reduce this toxicity.
Okay, so this is a major finding because it's often done, this calcium and magnesium, and it is in a way obsolete now. You don't have to do it anymore because there's practically no effect in the adjuvant setting and also in the metastatic setting. But this was a study in the adjuvant setting, I think.
This was a study in the adjuvant setting, but I think we can extrapolate the data because this was a very proper setting, very intensive monitoring of acute and chronic neurotoxicity, so we can have this information and extrapolate to the overall setting of oxaliplatin treatment.
Okay, it's a really bad side effect, and I always fight with the patients against this side effect because it's really disturbing, and there's absolutely nothing we can do now against this. This is your opinion. There's no situation where we can do anything.
Another finding from this trial, which was done by the Allianz group, was that you need to do dose adaptations. You need to reduce the oxaliplatin dose in order to prevent high-grade neurotoxicity. I think this is the take-home message. You need to do it, and in the US trial, most patients actually had a dose reduction during the course of the 6 months chemotherapy.
Okay, so no other way than dose reductions, but not too much, otherwise we lose efficacy of oxaliplatin. So that's a difficult way to go, but calcium magnesium does not help. One major study, calcium magnesium. Let's go on. You said something about maintenance therapy. There was some new data from the Swiss, also from here, and from the Dutch group about maintenance in colorectal metastatic disease. What were the main findings there and your conclusions?
Well, to conclude very briefly, the main finding from the Dutch study investigating the value of continuing capecitabine plus bevacizumab treatment after induction chemotherapy with Capox plus bevacizumab compared to doing nothing, observation alone, was that there is a large difference in time to progression, which reduces if you look to the time beyond progression, time to second progression. There's still a difference which is significant in this trial, and this also transfers to a small but significant difference in overall survival. Therefore, I think treating patient with this type of maintenance therapy is of benefit in some patients, and you can prolong not only intermediate time points, but also for small magnitude, also maybe overall survival. I say maybe because the overall survival data are not quite mature. We have to wait for this, and we also need to wait for subgroup analysis, which are done by the Dutch colleagues in order to look at more deeply which patient get a benefit from maintaining chemotherapy versus giving them drug-free holidays.
Okay, so this is take-home messages from the Dutch that you can, or there is an additional benefit of continuing chemotherapy de-escalated without oxaliplatin, so you have the Capox bevacizumab and you go on just with capecitabine. Bevacizumab, you go on after 4 months with that, and some patients do actually benefit, of course, with progression-free survival regarding immediately, this is obvious, but also a little bit with overall survival. So it's a strategy for some, but we don't really know who is benefiting from this, and it's a little bit, I think for some patients it might be a possibility, those who are not so holiday, who don't want to go on holidays, but the other ones, I think it's also a possibility to make a break. That's still that's still a good way. Then what did the Swiss trial show? So there was a little bit different design there?
The design was different in terms that we compared continuing bevacizumab therapy after induction chemotherapy plus bevacizumab versus no treatment, observation alone. And we can show that the difference in time to progression, the primary endpoint of this trial, is different in terms of a 5 weeks difference. And there was no statistically significant difference in overall survival. There were a difference in treatment costs of about $30,000, which make this strategy questionable if you should maintain bevacizumab monotherapy, which is well tolerated, but the effect is rather small.
Okay, so this was in the label, how we should use bevacizumab, at least in Switzerland. After first-line chemotherapy with bevacizumab, you have to go on, or you are supposed to go on with bevacizumab, and now you show that the benefit is actually really small and it costs quite a lot. And taking also the Dutch data into consideration, one could say, well, if one goes on with something, if they have to come, one goes on with a slight chemotherapy with bevacizumab. Makes more sense to me, at least if one wants to go on with anything. Is this your opinion too?
Yeah, I agree. I think offering patient a treatment-free interval is attractive and should be considered in some patients because the time you can have without chemotherapy is still some months, which is of great value for a patient with an incurable disease. However, if you decide to continue treatment, you should better use a combination of chemotherapy plus bevacizumab and not to use the bev alone treatment.
Okay, so that's a good and clear conclusion from the Swiss trial. There were some data about more intensive testing regarding KRAS, some NRAS and BRAF data. What was the background of this data?
Well, the background of this data is that we have implemented KRAS mutation testing in clinical routine in the past years. This is done all over the world, more or less, and is based for decision making if patients should receive an EGFR inhibitor or not. So KRAS status is still routinely done. Now the question of this trial is, should we look beyond exon 2 mutations? So they looked to exon 3 and 4 mutation, and they looked also to NRAS mutations and on BRAF mutation, which have rather an influence on the prognostic value. BRAF mutated tumor patients have a poor prognosis of about 10 to 11 months compared to other patients who don't have this mutation. But the main finding is if you look to low frequency mutations, the effect of the EGFR inhibiting strategy done during first-line chemotherapy, this was analyzed from a large phase 3 trial called the PRIME trial, which assessed FOLFOX chemotherapy plus or minus panitumumab. If you look closely, the effect on the overall survival is of 6 months of difference. So there's a large difference in this retrospective analysis. And yes, you need to validate this on other trials as well as, if possible, on prospective data.
Okay, so it's very interesting because if one considers how this all developed, the KRAS testing was panitumumab had difficulties to get on the market. They looked into the data and found that only KRAS wild-type patients benefited. And now they dig even deeper into other data of their trials, of the Amgen trials, and they see that if they go when they go deeper, you even increase the efficacy even more of the EGFR antibodies. So it's interesting for me also from the market mechanism, that these companies are under pressure to find or to put drugs on the market, and they can only if they show efficacy. So they have to dig really deep into the data, and now they find if you also go to exon 3 and 4 on KRAS and also NRAS, you increase efficacy. And that, I think that's really interesting, and I'm really curious to see how this evolves, because this is now the first set of data, and probably it has an effect and makes sense to test it, because then you really know if the drug is efficacious or not. Do you agree or think?
I agree, especially in the setting of neoadjuvant chemotherapy before doing metastasectomy. You want to have a very good response, and if you want to look very closely and deeply to this mutation, and you rule out this mutation, also the response rate tend to increase, so the effect is purer. However, you can only offer about 34% of patient anti-EGFR treatment. So the number of patient, or the percentage of patient you treat with an EGFR strategy, and if you look closely to this low frequency mutation, are getting smaller and smaller and smaller.
So they were once 50% more or less, KRAS wild type, and now it goes down to more or less 30% if you take all the mutations into consideration. Yes, you have less patients, but they benefit more. So I think it's a really interesting finding, and one needs to see how this evolves. But this is probably for some patients already practice changing, because if you, as you said, in the neoadjuvant setting, a really interesting finding, and you have to consider it. Perhaps last but not least, the MPACT data in pancreatic cancer. There was really also a practice-changing study was already presented at ASCO GI, I think.
Yeah.
What was this trial about?
This trial was about first-line treatment in patient with metastatic pancreatic cancer receiving either gemcitabine as a standard monotherapy or a combination of gemcitabine plus nab-paclitaxel or Abraxane. The second compound was added to the standard of gemcitabine and resulted in an increase in tumor response rate, progression-free survival, and also overall survival of about 2 to 3 months. This is of great value for patient, being another option between FOLFIRINOX chemotherapy, a triplet chemotherapy, or a monotherapy, which is still of value for some patient with impaired performance status or elderly patients, which can be still treated with gemcitabine. Now you have a third option to combine two drugs and have this kind of good effect in terms of increasing the effect to the patient, which is of value usually in the palliative setting, because you gain a clinical effect which might be important for the patient.
Okay, so we have now 3 regimens: the gemcitabine, the old one, then the nab-paclitaxel, gemcitabine, and the FOLFIRINOX. The Conroy data last year, was it really, the Conroy, the FOLFIRINOX is really toxic, and I think this nab-paclitaxel, from the data, from personal experience, very limited, is much better tolerated. I think it might be really good alternative, but it is difficult to see where the regimen fits in, because
we need to sort out. However, I can see just as an approximation about 1/4 to 1/3 of patients are eligible for FOLFIRINOX chemotherapy, and about 50% or even more, we need to learn more from a practical standpoint, are eligible for a doublet chemotherapy with nab-paclitaxel and gemcitabine.
Okay, great. So practice-changing study. It will influence everyday life in the clinic. Dieter, thank you very much. It was great talking to you. See you again perhaps next year. Bye-bye.
Bye-bye.